you very much. So in trying to think of a case that I could present, I wanted to have some wounds, I wanted to have some complications, or at least as a learning point. So I thought this would be a nice case with a blend of both. If there's any doubt within the crowd, clearly PK is the king of CLTI.
This is why you should
okay
never
for
allow
those
Dr. Coombe to photography.
Those who want this, for those who want a copy of a high-def copy of this PK, that's going to be $50 every shot. But anyway,
It's a real picture.
we're going to make sure I get a bottle of that nice Bordeaux Burgundy tonight. But anyway, so this is a case. It's a pretty old lady, 87-year-old, diabetic, hypertensive, pre-morbid. She was an ambulatory patient. Valvular heart disease, TRMS with a PSP of about 45, so quite high. Charles A. liver cirrhosis, peripheral vascular disease with a very stable right toe wound. And she went to another country and had an angioplasty and a drug-coated balloon of an SFA and POP, and the peroneal as well. The anterior tibial was a failed attempt. The drug-coated balloon, I'm not sure if this is available in the US, but it's a Paseo Lux from Biotronic. And this had just been performed 1 week ago in another country. And she came with worsening duskiness of all the toes and pre-gangrenous looking thing in the instep of the foot, a little bit of pain as well, and also on the heel. When she came in, her whites were elevated, a bit febrile. The MRI, of course, first instinct is this a infection in the foot? MRI showed no collection in the foot, but diffuse muscle inflammation in the calf, and CKs were elevated in the 800s. Dialysis catheter turned out to be infected, not the foot. We got that sorted out pretty quickly, and antibiotics had gone in. So within a 3-day period, this is the usual way that we would treat all these patients. This is a typical way that we would do an ultrasound, and the sonographer would run an ultrasound rather than a CT scan if you can feel a femoral pulse. So as you can see, this is similar to an angiogram. The SFA pop looks pretty clean. The anterior tibial looks diseased. The dorsalis pedis is running at 11 centimeters a second, probably from flow from a biphasic peroneal artery, and the posterior circulation has tandem occlusions with spots of islands of patent vessels. So the right leg was a symptomatic leg. So this was 1 week post-angioplasty. The proximal SFA had a lesion. There's a piece of rock at the adductor canal and a bit of disease in the P2, P3. Peroneal looked like it's running down. And then looks like there's some flow. Distal anterior tibial is patent in what looks like a tarsal artery. Some rock further down as well. So the target in this case was the anterior. So this is typically how we would revascularize with a 4 French catheter and an 014 wire. We were able to wire down this lesion. Looks promising so far, and the wire sat in the TAS, what looks like either the DP, and as you can see, some flow to confirm pre-dilatation with a coyote balloon. And this is where the problem started. We could pass the lesion with the wire, but we could not run in a 1 millimeter Sapphire 3 Pro. Because of that, we did a distal AT puncture, and even with the distal AT puncture and a bad form pull-through technique, we were unable to get any balloon across. And then we just decided, okay, next we'll do a kebab, and we started to pierce this lesion. And even after we pierced this lesion, a little bit of difficulty and trying to yank the balloon down, we were finally able to balloon that lesion with a 2 millimeter high pressure non-compliant jade balloon. That opened up the lesion fairly well, and we thought, okay, things are looking quite all right so far. So we move on and we go south and we chase it all the way. And before we wire it down and we cross the sheath with another wire, typically we like to cross and secure that distal access before we pull our wire. So this was performed, and we'll pull the wire and with the balloon down. And with the balloon, we could see there's a little bit more lesions further south. And on AP configuration, and this is a bad sign when you see that hazy looking thing, the wire would traverse, and we thought that was the end of it. But again, we had another lesion again that we could not cross, even with a 1 mil balloon. Typically, in these cases, we would aggressively pre-dilate to bring down some stuff, but eventually, without this 1 millimeter balloon, we had to pierce this leg again in the distality, and with the 1 millimeter balloon, we were able to do a pre-dilatation and send a further balloon down. Prepping the lesion with a 2 millimeter jade balloon. This is a high pressure non-compliant balloon that we typically use for most of our BTK cases. As you can see in both AP and lateral configuration. Flow was not that great, still a bit chugging down a little bit, but the peroneal looks a bit funny. I think something has gone wrong further down in the peroneal artery. Something has flown down the peroneal artery. The flow in the AT was running, but needed further optimization. At this point in time, we looked at the inflow. We thought the proximal AT needed a little bit of encouragement, so a metallic drug-eluting stent went down. And then I started to chase the peroneal artery because I wanted to preserve the flow. Something I did must have caused the flow in the peroneal artery to get knocked off. At this point in time, a 4 French catheter and aspiration was done. And we decided to give a little bit of thrombolytic agent, a bit of urokinase went in. Let that marinate for a while and do an angiogram, and looked like the flow was getting a little bit better. Atypically AV fistulas, you can see. And flow was still better, but still chugging down a little bit. At this point in time, I decided that maybe it was an inflow, was an SFA issue. Subsequent to that, we decided to address the inflow. Honestly, can't remember too much about what happened, but clearly there was some outflow vessels, so the inflow needed to be addressed. In my practice, this would be, because it was a DCB failure, I took out the antegrade access and decided to stent the whole P3 area with a drug-eluting Eluvia stent. Typically, our experience with these kind of lesions that in our series is that if you mix and match with a superior on the south side and stack it up with the Eluvia on top, we had actually not good results with a combo stent. We prefer to use a oversized Eluvia stent and get total lesion coverage all the way up. And this is a case where drug-coated balloons had already been implanted 1 week ago. Subsequent to that, you can see that the flow looks pretty decent, and we decided that we'll pull out and just address the wounds. At this point in time, because all the toes had looked dusky, there's a possibility there's some infection despite what the MRI says. I decided to do what we call a guillotine disarticulation. We leave the caps on, and you can see the mid portion of the midfoot has started to have some gangrenous lesions. There was no pus. Typically, we would disarticulate to decompress the foot, and you can see that's getting worse on the middle portion, but you could see some hint of granulation in the anterior circulation. Doppler signal was really good at this point in time. 1 month later, however, the anterior tibial went down again. It was on duplex ultrasound. There was a fall in the PSVs, and we went for re-intervention. This is an antegrade stick in through the stent that we had implanted, so we cannulated through the stent. That portion of rock is a little bit, about 30%. You can see the flow down the AT is significantly slower, and there's a portion of the AT that had occluded with what looks like a soft clot, a trickle of flow. At this point in time, it looks like a very precarious situation with a catheter. We decided to do lyse, give a bit of thrombolytic agent, and do a slow lysis through a 4 French catheter. And suck on the 4 French catheter looks significantly better with restoration of flow. However, I wasn't sure that there was any clots in this very tricky lesion, so we decided to put in a spider filter and then do balloon angioplasty of this lesion. As you can see, a spider filter there. And subsequent to the spider filter and balloon angioplasty, we're still seeing recoil in this vessel, despite high pressure, oversized, non-compliant balloon. At this current point of time, I didn't have a lot of options left. This is a patient that has already quite extensive soft tissue loss. So we're in a restenosis within a month. Decided at this point of time to put a Ranger drug-coated balloon in the distality and essentially stack the whole artery up with scaffolds and drug-eluting stents. So this was performed once we had this good angiographic result, we decided to preserve it with a barrage of hardware. And these are the completion angiograms with improved flow by treating the bad disease. You can see actually flow going up the veins and the wound blush and the dorsum of the foot. Peroneal is still looking pretty decent, and you can see some digital vessels. What's the clinical cause of this patient? Once we restored flow, we decided to remove the caps and expose the cancellous bone. We put on a wound vac and did all the usual bit. My typical regime for this patient is 2 eggs a day to bump the protein up. With that, we were able to slap on a skin graft at 3 months, and this is a Doppler just done a couple of days ago, which shows patent in and outflow vessels at 4 months. In this case, I suspect pachytaxal embolism. Why? Because this particular brand of drug-coated balloon is known to be pretty flaky. This patient had a stable first wound without the dusky toes. After the SFA intervention, she started to get all these dusky toes. Probably the only thing that was different in that case was probably the pachytaxal. The CKs were elevated. The MRI showed diffuse muscle myositis. So I think that this is an example. The lessons to learn is I would generally avoid extensive drug-coated balloons with patients with poor outflow and use a drug-eluting stent. Dialysis patients are tricky in terms of revascularization of wound care. I feel that the Achilles heel of a drug-coated balloon is still the balloon without sufficient lumen gain. And I'm waiting for a long drug-eluting stent, 120 millimeters long and cheap. Thank you very much.